Hello, everyone, and thank you so much for joining this talk on cannabis conversations, legal and behavioral health considerations for social service professionals. My name is Dr. Bridget Murphy. I'm an assistant research professor in the Zuckerman College of Public Health at the University of Arizona, and I am joined by my colleague, Will Humble, and we'll do some greater introductions in just a moment. AzCANN is a cannabis education program delivered by the University of Arizona's Comprehensive Pain and Addiction Center. It's important to know that this grant is supported by the Arizona Department of Health Services, and the contents are solely the responsibility of the authors and do not necessarily represent the official views of the Arizona Department of Health Services. And this is a collaboration with the Comprehensive Pain and Addiction Center and the Arizona Poison and Drug Information Center. To start, it's important to acknowledge the land on which the University of Arizona is situated. It is on the land and territories of Indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the Atum and the Yaqui. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign native nations and Indigenous communities through education offerings, partnerships, and community service. Now we're just going to take a few moments to introduce ourselves, and I'm going to ask Will if you would just take a moment to introduce yourself, and then we'll come back to me. Thank you.
Thanks, Bridget. My name is Will Humble. I've been working in public health for about 35 years in Arizona. Most of that I spent at the Arizona Department of Health Services in various different positions, including being fortunate to being asked to be the director during the Brewer administration. And that's when the Medical Marijuana Act passed in November of 2010. So I had the pleasure of implementing the medical marijuana program while I was in that director position. And since then, I've moved on. I left at the beginning of the Ducey administration and now have been the executive director for the Arizona Public Health Association. We're a nonprofit organization that really mostly does advocacy for evidence-based public health policy.
Well, it's a pleasure to have you on this talk, and we're really fortunate to have your expertise on this particular subject. As mentioned, my name is Dr. Bridget Murphy. I have a doctorate in behavioral health and have been in the area of substance use prevention, harm reduction, treatment, and recovery for over 30 years, which does not include my adolescent treatment stay in a long-term residential program when I was a teenager back in the 1980s, which really set the foundation for my work in this area. I am a firm believer in the topics of prevention, harm reduction, treatment, and recovery, and have seen the field grow tremendously over the last 30 years to really have evidence-based prevention, treatment, harm reduction, and recovery strategies. So looking forward to continuing to be with you all on this talk. So let's just give you a little bit of relevance for the understanding cannabis within social service professionals. First, it's really important to understand the prevalence. And so when we look at the prevalence among people 12 years or older, cannabis was used by 52.5 million people. And that is over the population of the state of California. So a lot of people are using cannabis. What's important to know is that used means even one time. So understanding that there are a high number of people using cannabis in the United States, and 16.3 million people are meeting criteria for marijuana or cannabis use disorder in 2021. And that's about a little bit less than the population of Illinois. And what's important about that is a diagnostic criteria for cannabis use disorder, which we'll talk about more as we progress throughout the webinar. Also, we know that for prevention and harm reduction, recreational cannabis use does increase motor vehicle accidents and deaths. And one of the most important predictors for future problems is the age of onset. The earlier somebody uses cannabis, the more likely they are to develop a cannabis use disorder. So prevention is really important to keep young people not using cannabis until they're older or later in time. In terms of treatment, There is evidence to show that cannabis is effective for treating neurological disorders as well as chronic pain. What's important to know is that each different disease condition has a different rate of progression and different types of treatment. So, understanding that cannabis has good evidence to support neurological disorders such as multiple sclerosis as well as chronic pain is what we know today in terms of its effectiveness. And then also, it's important to understand that there are differential rates, modes of administration, protective and risk factors associated with cannabis use among culturally and linguistically diverse populations. So we know that polysubstance use predicts greater problems associated with cannabis use, as well as co-occurring issues, anxiety, emotion regulation, and disadvantaged communities. So really important to understand that cultural and linguistic diverse populations have different reasons for using cannabis. With that, I'm going to turn it back to Will.
Thanks, Dr. Murphy. And so here's what I want to do next is just take a couple of minutes and set the sort of legal stage in Arizona going back a couple of decades. Obviously, marijuana has been illegal under state law going all the way back to statehood, even before that as a territory. Well, actually, maybe not, but at least going back to statehood. And there was a big change in the late 1990s when the voters actually passed a voter initiative that legalized medical marijuana, and it established a medical marijuana program. Voters approved that actually in the late 1990s. Well, what happened was the state legislature didn't like what the voters did. So they basically disassembled that voter initiative. Needless to say, a lot of people were kind of pissed that the legislature undid what the voters had approved. And what we then got was the Voter Protection Act, which was called Prop 105. This is in the early 2000s. And so when you hear the legislature complaining that they have an inability to make changes when there's a voter initiative because they have to have a supermajority to do that, they can blame previous legislatures for having disassembled the medical marijuana program from the late 1990s. So the voters approved Prop 105, the Voter Protection Act, and that's the protection that we all enjoy now for all voter initiatives. Take even, smoke-free Arizona as another public health example, and medical marijuana that was then passed in 2010. So the protections that we have in place for voter initiatives in terms of legislative meddling actually go back to the original medical marijuana program from the late 1990s. Many bills had been proposed through the early 2000s by the state legislature to both decriminalize marijuana and also to establish medical marijuana programs. To my knowledge, none of those bills were ever given even a hearing down at the state legislature. But enough momentum built up over time that enough signatures were gathered in 2010 to put the medical marijuana program on the ballot in November of 2010. By a fairly healthy margin, I would say. It wasn't, I think it was 52-48. You can thank Pima and Maricopa County for that, because every other county voted no on that medical marijuana initiative except for Pima and Maricopa County. But the margins in those two counties were wide enough so it overcame the no vote in the rest of the state. We were charged at the state health department with putting together the medical marijuana program in 2010. We did that. The statutory language that the voters approved really, I would say, gave the skeleton of the medical marijuana program. And then we at the department were responsible for making it into an actual organism. So the administrative code or the rules that we built as an agency brought the statutory medical marijuana program to life so that we could actually implement it. And that's the origin of the dispensaries that you see out there in Arizona. There were lots of other protections in place that the medical marijuana program did. We'll get to some of those in a bit. But as the program matured, there was a growing movement to move past medical marijuana and just create an adult use program. And as all of you know who are watching by now, that the voters passed that a few years ago. And now we have both an adult use program in Arizona where you do not need to buy a medical marijuana card. You don't need a medical assessment. And you can buy marijuana at dispensaries up to an ounce only. But we still have alongside that a medical marijuana program that still exists. And we'll talk about who that medical marijuana program primarily serves these days, given the passage of the adult use marijuana program. So now we can move into some of the detail. So here are just the real basics of it. Medical marijuana is available to kids at less than 21 years old, as long as there's a medical assessment. For kids under 18, it requires 2 physicians to sign the medical marijuana card. But for medical use, it's available even for kids under 18. Again, there are some safeguards in there to make sure that there's physician assessments and so forth. Patients need to buy a card from the state health department. Those cards cost $150 in the last 2 years. I will do a mea culpa that I set the fees at $150. It was way too high. That's why more than $100 million in extra money was generated off of patient cards over the first 8 years of the program before I left the state health department. Had I known we had this many patients, I just wouldn't have set the fee that high. But it's important as you go through your career to admit your own mistakes. This was one of mine. Products are available at dispensaries. Recreational use, which I call adult use program, is available to anybody over 21. You don't need a medical marijuana card. You just need an ID to prove that you're 21. You don't need to be an Arizona resident even. You could be from Canada and show your passport. Doesn't matter. There's no administrative fee for patients. You can buy up to 1 ounce at the dispensary for recreational or adult use. The medical marijuana program allows you to buy up to 2.5 ounces every 2 weeks. On the medical program, qualified patients buy at the department's licensed dispensaries. That's the same as on the adult use program. There's an interesting piece of the medical law where patients can get marijuana or cannabis from their caregiver for free. That was a super popular option in say 2011, 12, and 13. I think the caregiver piece has sort of dropped off a lot as the dispensaries flourished in the 2011, 2012 period on the medical side. Patients can give each other marijuana, cannabis. That's in the Medical Act. And that medical law was limited the number of dispensaries to 10% of the number of pharmacies in the state. So right now that's about 140. On the adult use side, you need to be 21 or up. No kids, no one 18, 19. For that, you'd have to have a medical marijuana card to get it. Adults can grow up to 6 of their own plants. They need to secure those plants. They can't grow them in the backyard where kids can climb the fence and stuff. So you need to make sure that you got to manage that marijuana properly as you grow it. Same number of establishments, about 140. A little bit more than that because there was a social equity program that was put into it at the last minute. And the existing medical marijuana dispensaries qualified to become adult use, but they had to meet some standards and so forth. And of course, comply with the regulations. Penalties per possession. So if you have a medical marijuana card and you have less than 2.5 ounces of marijuana with you, and it's for your own use, and you have your card with you, then you cannot be prosecuted for possession of marijuana. Same with patients under 21. And the important thing here is the 2.5 ounces piece. On the adult use side, again, you don't need a card. You just need to show that you're 21 to benefit from the recreational or adult use program. You can have 1 ounce or less on you. Now, we're going to talk about driving and stuff like that in a minute. But you can have 1 ounce or less of marijuana with you, and you cannot be prosecuted for anything. If you have between 1 and 2.5 ounces, and your law enforcement can pop you for what's called a petty offense, which is kind of like a little bit less than a parking ticket, I would say. So it's not a huge penalty to have between 1 and 2.5 ounces. But if you have more than 2.5 ounces on you, you can be prosecuted and charged with felony 6 possession of marijuana, cannabis. There's 2 different definitions in state law. We won't get into that. So 2.5 ounces you can think of as really the do not pass level. If you've got more than 2.5 ounces, you could be in trouble. So don't feel like you've got safe harbor for no matter how much marijuana you've got for your own personal use. It needs to be less than 2.5 ounces to avoid penalties. And you can see this bottom piece here about what the fines are for between 1 ounce and 2.5 ounces. But 2.5 ounces is the thing to remember, because that's where you can really get into trouble if you've got it. Impairment. This is a really important part of the whole discussion. Basically, this is an area where there's hardly any difference between medical use and recreational or adult use of marijuana, both in the Medical Marijuana Act and the Safe and Smart Arizona Act. You can't drive while impaired, period. That doesn't matter if you got a card or not. Doesn't matter if it's an edible or you smoked it. You can't be impaired. Now, employers can require impairment-free workplaces. So the Adult Use Act didn't give you safe harbor to smoke weed at work, doesn't give you safe harbor to come to work stoned. Employers can fire you for that. I mean, they can. Now, if you've got a medical marijuana card, you still can't go to work stoned. They can still fire you for being high, but they can't fire you for just having the metabolites in your bloodstream. So there's some employment protections under the medical law, not the retail law, but the medical law. You've got some protections if you buy a card. So if you're concerned about your employer firing people because they've got metabolites of marijuana in their system, and you're a user, that may be a reason why you did put down the $150 and buy your card, because you would also be buying some protection from being canned by your employer for having metabolites in your blood. And regardless of both the medical and adult use law say you can't smoke weed in public. This is just the DUI law, and as I mentioned before, you can't be high while you drive, period. Same if you've got a medical marijuana card, you may be able to fight if you're pulled over and are charged with DUI or impairment to a lesser degree than that. You may be able to fight it a little bit if you've got a medical marijuana card, because the metabolites of marijuana in and of itself aren't enough to establish that you were impaired. If you've got a medical card, you don't enjoy those same protections just under the adult use law. So the bottom line here is just don't do it. If you're impaired, even to the slightest degree, don't take the chance. Here's just sort of a benchmark from Colorado about, that is, if you get popped, don't think that your lawyer can get you out because of these things. But smoking less than 6 hours ago, a half a joint, probably still impaired. Edibles, here it says one serving at 10 milligrams at 8 hours, but everyone who's watching probably knows edibles are like, you can be high for a really long time on edibles, depending on how much you have. And that's the thing. And I want to do some color commentary here. As we did the medical program and established it, I got a lot of questions from journalists about whether smoking or the edibles was a better option for public health. And I think some journalists were surprised when I suggested that, there are some advantages to smoking. Yes, there's combustion products and that kind of stuff. But at least when you smoke marijuana, you know how high you are right away. And so there's better opportunity to self-regulate. That's not the case with edibles. Once you swallow it, once it's in your gut, it's there. And if you took way too much, there's no going back. You're going to have to ride it out. So the self-regulation piece of edibles, I think, poses an unrecognized or an under-recognized public health threat because of this driving issue, but also workplace and other problems that can happen when people eat too many edibles and just get super stoned. Okay, expungement. This is the reason why I supported the adult use law, is the expungement piece. I am not a huge fan of the retail stores being open to anybody, especially with the adult use law being so, with the penalties for purchasing and possession for people under 18 being so low, there's really very few reasons why a person 21 would be afraid to smoke marijuana, and it makes it so much more accessible, having the retail stores open to everyone, even non-card holders. So I was reluctant to support the adult use law because of the additional risk of adolescent use, which Bridget talked about at the beginning. But even with those reservations, I was compelled to support the adult use law because of this thing right here, expungement. County prosecutors kept saying during the campaign that nobody does jail time for small amounts of marijuana. And some do, they're lying about that. Some do. But the public health threat from that charge and that conviction isn't the jail time. It's the felony conviction being on your record, which impairs your ability to be employed through the rest of your life because you have to keep checking the felony 6 box, as you apply for jobs. And that reduces your ability to support yourself and your family. So for that reason, I was a big supporter of the adult use law because I felt like it was the only way to get expungement and to prevent future convictions for possession of small amounts of marijuana for felony convictions. I thought the voter initiative was really the only way to do that. So what is expungement? What it means is that if you've got a previous conviction for possession of marijuana, if it's a small amount, you're able to get that off your criminal record. If it was an Arizona offense, you can't get your federal crimes expunged, but if it was a state conviction, you can. But unlike other states, there are a bunch of other states which expunged historic convictions of small amounts of marijuana, expunge it retroactively and without action by the resident. Arizona, you have to apply for expungement. So it makes it a little bit harder than it is in other states. There are opportunities for you to do that. You can just use Google and figure out, ways that you can get help with expungement. The state health department actually has a program that they fund that helps people to get their convictions expunged. But a big and important thing, I think, for many people who want to improve their employment prospects, but have a historic conviction of some small amount of marijuana on a felony charge. What are some of the eligible pieces? If your conviction is less than 2.5 ounces, when I said earlier, I said small amount, what I meant is 2.5 ounces. So possessing, having 2.5 ounces or less, or 12.5 grams of the concentrate, you can apply for expungement for that conviction. It's really for possessing, transporting, or cultivating more than 6 plants. You can have that. There's some people have been convicted of that. You can apply for expungement for if you was paraphernalia. A lot of county prosecutors, they'd bust you for the weed and bust you for the bong, both of which were felony 6s. You can get the paraphernalia convictions expunged as well. What you can't get expunged is if you were stoned and driving and got a DUI. If you had 3 ounces or 2.5 ounces, more than 2.5 ounces, put it that way, no dice. That stays on your record and doesn't apply to anything, heroin, any other kind of drugs, things like that. So what we've been talking about so far is Arizona state law, Arizona law. Arizona voters approved stuff on Arizona property, Arizona land. Does not necessarily apply to Native American tribal governments, tribal nations, tribal governments. And you can see those in the darker shaded areas here. As you just said in the land acknowledgement at the beginning, we've got 22 federally recognized tribes and tribal governments, and those tribal governments decide what happens on their tribal nation. They have sovereignty. They can decide what they want to do with this stuff. So don't think you can pull out your weed and Kayenta and everything's hunky-dory. You can get charged by tribal governments for possession and other things with marijuana. So this is just a cautionary thing to, for everybody to say, hey, look, we've been talking about Arizona state law. Tribal governments can do their own thing and have their own penalties. They have their own courts, most of them. That's just something to keep in mind. Okay, now that's the end of my piece. So Dr. Murphy, take it away.
Thanks, Will. That I think talk really helps us understand some of the legal issues associated with cannabis use in the state of Arizona. And now it'll be a good primer for what's important about that and other issues for social service and behavioral health professionals. Okay, so just let's take a quick snapshot on the brain. And when we're talking about psychoactive drugs, and we're talking about psychoactive drugs for cannabis, we're talking about tetrahydrocannabinol, also known as THC. That is the psychoactive ingredient in cannabis. But it's what's important to know is that cannabis, the plant, has over 500 chemical compounds. But THC actually mimics and is a similar chemical structure to natural occurring neurotransmitters in the brain. And so when we think about how the brain sends and receives messages, can look at neurons or communicate through these electrical and chemical signals. Neurons are these receptors, and they read and pass a message on. And the neurotransmitters are the chemical messengers that travel across the synapse. And so psychoactive drugs such as cannabis, the THC in cannabis, act in a similar way to naturally occurring neurotransmitters in the brain. So, endogenous cannabinoids in our body function as neurotransmitters, and they influence the issue of pleasure, memory, thinking, concentration, movement, and time perception. And what THC does is it attaches to those cannabinoid receptors and activates them, basically interrupting neural and disrupting neuronal communication. So the next two slides, we're going to talk about not only is it important to understand how THC functions in our body, but also what are some of the social and contextual issues associated with risk and protective factors. And so the first slide here, we're going to talk about the social ecological model, where we can look at the policies and environments, communities, organizations, and interpersonal connections, as well as individual family risks associated with cannabis use and misuse. So, first, we can look at adverse childhood experiences, trauma, toxic stress. As was mentioned several times throughout this talk, is early initiation of use. So, the younger a person uses, the more likely it increases their risks. And then family conflict and management problems are those individual and family risks. When we look at interpersonal connections, this is peer substance use. So if a young person or an adult has peers that use cannabis, it might be more likely to influence their risk of using and misusing cannabis. Favorable attitudes towards drug use and organizations. So transitions and mobility. What are the organizations within a community, and are they long-standing organizations in those communities, such as schools or healthcare organizations? And then communities, is low cost and high availability. Is it available in communities? So cannabis, what is the cost associated with using that particular drug, and is there high availability of that? And then finally, the laws and norms associated with substances. So in Will's talk, we can see how the changing laws and norms associated with cannabis, both for medical purposes and adult recreational purposes, really does influence the availability and the cost and our attitudes towards that particular drug use. Similarly, we need to think about the protective factors or the developmental assets that people have. And this we've just put in relation to the social determinants of health. So the social determinants of health, as defined by Healthy People 2030, are education, access and quality, economic stability, healthcare access and quality, neighborhood and built environment, and the social and community context. All of these determinants really have an influence on the health decisions that we make in our lives. And when we think about some of the protective factors that communities can implement, we can think about schools and having a caring school climate, safety and bonding. Economic stability is making sure that there's equality. Will talked about the social equity initiative as it relates to the cannabis, and making sure that people who have been disproportionately affected by cannabis laws have an opportunity to have business opportunities in that area. Also thinking about social and positive view of the future. So if people have the economic supports in place, it provides them potential for a positive view of the future. Healthcare and access are opportunities for positive and social involvement. So, do people have an opportunity to make decisions about their healthcare in collaboration with their healthcare provider? And do those healthcare providers and organizations have cultural competence and are responsive to the cultural and linguistic needs and preferences of their patients? And neighborhood and built environment, healthy beliefs and standards for behavior, creating activities as well as safety. And social and community context is thinking about those boundaries, high expectations, self efficacy, and support. These are some protective and developmental factors associated with prevention of substance use and cannabis use. So let's just talk briefly about health promotion in action. So there are different levels of prevention. So when we can think about prevention, we can think about universal, selected, and indicated prevention. And the universal is prevention activities that are aimed at everybody in a certain group. So everybody in a healthcare organization, or everybody in a school, or everybody at a workplace. What are some things that we can universally do to prevent the harms associated with substance use or cannabis misuse? Selected are those individuals that are at risk, maybe have some of those risk factors that we just talked about, and how do we utilize different interventions to help prevent long-term adverse consequences associated with cannabis misuse? And then indicated are those that have been using a substance such as cannabis, but have not reached the level of meeting criteria for a cannabis use disorder. So thinking about the different levels of prevention, and we're going to talk about these, putting these all together in just a moment. Cultural and linguistically responsive services. So, the Office of Minority Health several decades ago developed standards for healthcare organizations to provide culturally and linguistically responsive services. And several years ago, not 2 decades ago, but several years ago, the Substance Abuse and Mental Health Services Administration, in collaboration with the Office of Minority Health, developed behavioral health culturally and linguistic responsive services. And these are really important to think about implementing within our healthcare organizations and behavioral health organizations. Harm reduction is utilizing evidence based strategies to reduce harms associated with substance use, misuse, and including cannabis use. So, Will just talked about the difference in the route of administration of using cannabis, either smoking or through edibles, and understanding, letting people know what are the different rates of progression that one feels the effects of these drugs, either edibles or smoking, and ways to reduce harm. So, for instance, if somebody's going to use an edible, to make sure not to use another edible in a short amount of time just because you're not feeling the effects of that edible, because it takes a little bit extra time to get to the brain because it goes through the digestive system. Access to and levels of care. So, not only how do people get access to care, there's factors associated with that in terms of the 5 A's, which are availability, accessibility, accommodation, affordability, and acceptability, are really important when we think about how do people get access to either primary care or integrated behavioral health care or specialty behavioral health care services. And the American Society of Addiction Medicine has different levels of care for people who meet criteria for cannabis use disorder or substance use disorder, as well as preventative measures of ways that different levels of care based on a person's severity. Then health information technology is a great tool to use to help coordinate care in healthcare and behavioral health situations, and as well as integrated behavioral health care models. So it was just in June 2020 when the US Preventative Task Force gave screening by asking questions about unhealthy drug use in adults age 18 years or older a B grade. What's important to note is that screening should be conducted and implemented when services for accurate diagnosis, effective treatment, and appropriate care can be offered or referred. And we know that we do have these systems in place for accurate diagnosis, effective treatment, and appropriate care in the state of Arizona. What's important to know about this is that typically this is tied to insurance reimbursement as well. So if the US Preventative Task Force gives solid grade to a certain healthcare process, it usually is tied to reimbursement. So, and we're going to talk about that in just a moment. Now we're going to talk about a public health model called screening, brief intervention, and referral to treatment, SBIRT. And we're going to talk about this because it has applicability to not only address problems associated with cannabis use, but really substance use and other types of drugs as well. And what SBIRT is, it's a comprehensive, integrated public health approach to the delivery of early intervention and treatment services for persons with substance use disorders, as well as those at risk for developing these disorders. So the screening really follows the universal aspect of prevention. The brief intervention could be for selected or those at risk or those that are not using at the level of a cannabis use disorder, but could benefit from some type of brief intervention. And we're going to talk more deeply about this in the next few slides. So what is the SBIRT framework? So you have the S, the BI, and the RT. So S is screening. And what's important to know about this is that these are validated tools, screenings, and they could be anywhere from 1 to maybe 5 to 10 questions. And screening is implemented in healthcare organizations and school settings. It's been implemented in juvenile and adult justice settings. It's been implemented in a variety of settings, but the idea is to use these validated tools with all individuals, not just because somebody sits down and might look as if they have a cannabis problem, but these are really used for all individuals. And the idea is just to detect concerns. The screening does not necessarily indicate that somebody has a cannabis use disorder. It just is a way to start looking for potential concerns associated with cannabis use or other drug use. The second is brief intervention. And when we talk about brief intervention, this really does mean brief. It could be anywhere from 10 to 30 minutes, typically maybe 10 to 15 minutes in a healthcare provider's office or a school nurse's office or with juvenile justice or criminal justice personnel, probation officer. And the idea is to just provide some feedback about their risk, get some advice for some decision making about their use and how that use may or may not fit within their goals. And then referral to treatment. So if the screening and potentially a longer assessment and the brief intervention don't seem to be what the patient needs, or there's not any producing any kind of change, they might need a referral to treatment. And this would be those who meet criteria for a substance use disorder and or a cannabis use disorder. And it could be specialty treatment, such as an outpatient or a residential or hospital based, really depending on the severity. So this is what a risk stratification example might look like. And this, again, can be applied in various settings. And so this pre-screen is maybe something that you do for all individuals. And it might be 1 to 3 questions, could be 5 questions, and just asks about substance use. And if that pre-screen shows a positive, then you might go on to a full screen, maybe a longer screening. If it doesn't produce a positive, then we want to make sure to reinforce that with the patient and let the patient or the participant or client know that you appreciate their healthy decisions and they're making some healthy choices within their current situation. But just because somebody screens negative at one time doesn't necessarily mean that they're going to screen negative at any time, because we know that substance use can change over time based on those risk and protective factors and contextual issues. And we want to make sure to do regular annual screening, just like we would do for any other health condition. Going back to that positive screen, if you might do a full screen, and then based on that, if they have a mild to moderate symptoms, or you might actually do a brief intervention right then, anywhere from, as mentioned, 10 to 30 minutes. And the brief intervention might include medications, behavioral strategies, and if they have low severity, then it might just be brief advice. So, giving some advice on their use and ways that they can reduce harm and how that might interact with their goals. And we're going to talk about that in just a moment. If the brief advice is effective, you want to still make sure to do regular screening annually. Again, things can change in a year or even a few months. And so it's really important to do these regular annual screenings. And then in terms of brief intervention, if those aren't working, then you want to step it up, moderate to severe. That's when you might make a referral to treatment. Similarly, if the brief interventions seem to be effective and the patient is reporting fewer symptoms or not as many symptoms, then you would go back to doing regular annual screening. So there are an enormous amount of screening tools out there. And at the end of this presentation, there is a QR code to the National Institute on Drug Abuse where you can look at a variety of different screenings and determine which ones might be best for you and your organization. So pre-screening tools, as mentioned, maybe 1 to 3 questions, and they just detect a need for additional screening. And screening tools are general questions about substance use and misuse. They might have specific questions to certain types of drugs. So there are specific and sensitive tools out there for cannabis use concerns. So you can find specific questions to certain types of drugs based on your organizational context. And as mentioned, there's a lot of different screening tools that are out there. Some ways to determine which ones to consider is always thinking about the sensitivity and specificity of the screening tool. So sensitivity is that if you asked 100 people if they used cannabis, would 100 people who actually did use cannabis test positive? So that's your true positive. And specificity are those true negatives. So if you asked 100 people if they used cannabis and they really didn't use cannabis, those are your true negatives. Think about your population of focus. Think about adolescents or adults, transitional aged youth. Are there cultural variations? So thinking about those as well. And then also organizational personnel tools and cultures, like do you have the resources? Can it be integrated into your EHR? Those types of issues to consider. So what might brief intervention or advice model look like is first providers raise the subject. Got to ask permission. Hey, may I talk to you about your cannabis use based on your screening score? You just raising the subject is a very powerful way to start an intervention. Provide some education and share information. So you are using at cannabis levels that might put you at risk for other issues. And I just want to share some ways that you might be able to reduce your risk. Thinking about motivation. Why does the person use cannabis? What are their motivations for using it? And maybe what are some of their motivations for not using it? And then create a plan of strategy and then make sure to follow up on that strategy. So we always want to make sure, for an adult, you want to make sure that it's self-directed decisions and person-centered. If we're talking about adolescents, it's really important to think about how to include their caregiver or an adult who can help support them and make some decisions as well. But thinking about the patient's efforts and strategies, motivational interviewing is an evidence based approach to discussing substance use as well as cannabis use, and always thinking about goals. How does the use hinder or influence their achievement of their goals? So, referral to treatment is probably one of the least studied aspects of the SBIRT model. But what it's important to understand is that it could be referral to specialty substance use disorder treatment, but it also could be referral to other services, like services associated with the social determinants of health, and thinking about ways that other services, referrals could actually help a person decide to reduce or eliminate their use of cannabis. And so what's important to know is you have to have a system in place. Know the referral sources that you're going to be providing them. Do they accept patients? Do they accept the insurance? Making sure that you have a system in place before you just start referring folks. Also, talk with the patient and family about what are the risks and benefits associated with participating in treatment. So, there are risks. Will somebody have to go to a treatment program and maybe miss work or those kinds of things? So, and how to overcome or reduce those risks. And then also highlighting the benefits, not only for health, but maybe other aspects of an individual's life, work, school, faith, partnerships. And then also, does the referral source accept insurance, or how is the patient and family going to actually pay for those services? There are specialty care. Are there local specialty care organizations? Is there telehealth medicine that can be used? And do these referral sources, are they culturally and linguistically responsive to the population? So in terms of financing, it's really important that SBIRT has commercial insurance, Medicaid, and Medicare. They do reimburse. And there are CPT codes for private insurance, G codes for Medicare, and H codes for Medicaid. And it can be from screening, reimbursed for screening, brief intervention, 15 to 30 minutes, and even greater than 30 minutes. So there's a reference at the end of this presentation to the Substance Abuse and Mental Health Services Administration that can give you more information on that. So, what's the evidence associated with screening, brief intervention, and referral to treatment? So, what we can say is that adults and transitional aged youth and adolescents, we've used SBIRT in a variety of different settings. And generally speaking, in the literature, there isn't a lot of discussion about the harms associated with SBIRT. So, what that tells me is that generally the literature reflects improvements, even though they might be moderate or small, or no change. The literature doesn't say that implementing SBIRT is harmful. So it might be produce moderate or no changes at all. But we do know that it does reduce healthcare costs. It decreases provider bias regarding SUD. So if introducing screening, brief intervention about substance use disorder, which is one of the most stigmatized health conditions, if we can decrease provider bias and just provide this is routine care, that has the potential to really increase access to evidence-based treatments. And generally speaking, patients think it's acceptable and likable, so they don't find it problematic. There are mixed results on effects on healthcare utilization, the different primary substance use. We do know that it's been implemented quite frequently with alcohol, but other types of drugs, we have less evidence, or motor vehicle outcomes. And there's mixed results for patients with cannabis use concerns. And I think that's probably because we don't know really, there's more to learn about that in terms of cannabis use for recreational versus medicinal purposes. And there's really inconsistent information about implementation fidelity. So, how well an organization is actually implementing the SBIRT model as it's supposed to be implemented. So, what some of these inconsistent effects could be as a result of not understanding the implementation process. We also do know that higher severity, so a patient with a higher severity, does show greater change as a result of SBIRT implementation, and SBIRT may help prevent escalation of future problems or greater severity. So what's important to know is that most people who misuse alcohol, cannabis, and other drugs don't develop a substance use disorder. They have families and friends and go to work and don't necessarily meet the criteria for a substance use disorder, but they might have problems associated with that. And people use and misuse psychoactive drugs for a variety of reasons: for fun, because they're peers, they're socializing, stress relief, pain relief, other health conditions such as HIV or co occurring disorders, environment, genetics, and their cultural context. Traditionally, we've treated substance use and cannabis use and other use disorders in acute care model, where we send people off to treatment and then we expect them to be all better and never really follow up with them. And we know that that doesn't necessarily work, that a chronic care model is much more effective. And particularly when we think about the mild, moderate, and severe substance use disorders, they are similar in course, management, and outcome to other chronic health conditions such as diabetes. But substance use disorders are typically not treated or monitored in the same way, and some might not be covered by insurance to the same degree as other health conditions. And there are varying levels of care based on someone's severity, and using a recovery management model, thinking about having people go to specialty treatment if they need it, but then making sure to check in with them regularly, and just like we would do with diabetes or other chronic health conditions. So let's put it all together. So we talked about the monitoring access. We talked about the cultural and linguistic appropriate standards. We talked about social determinants of health, integrated behavioral health, health information technology, American Society of Addiction Medicine. And when we look at the model of continuum of care, we can see enhancing health, primary prevention, harm reduction, early intervention, treatment and recovery, and where screening, brief advice, intervention, referral to treatment, and care management exists. So in an ideal world, we would coordinate and collaborate using all these various tools and evidence-based practices to implement a model for screening, brief intervention, referral to treatment, and care management to address cannabis use, misuse, and cannabis use disorder at every level of the continuum. Here are some resources that you can get additional information on the topics that we've covered. Here are the references, and I just want to thank everybody for their time on this important topic, and many thanks to my co-presenter, Will Humble, for walking us through the important legal aspects to cannabis use. Thank you, everyone. Have a great day.